All right. Good morning and welcome everybody to the National Association of Medicaid Directors Medicaid Forward Behavioral Health Launch webinar. I'm Lindsay Browning. I'm the Program Director for Medicaid Operations at the National Association of Medicaid Directors, and we're really pleased to have you all here for today's conversation. It's my pleasure to welcome you and to share this new product from the National Association of Medicaid Directors. And we're going to try to keep this as interactive as possible. So please ask questions throughout the conversation. And we're going to have a couple of opportunities for you all to weigh in on polling questions throughout the webinar. The NAMD Medicaid Forward Initiative is a new initiative that really seeks to elevate and support Medicaid directors as the Medicaid program plays a role in the nation's recovery from the events of the last year. Medicaid Forward Behavioral Health is the first of 3 reports that will do this. Medicaid Forward Behavioral Health was done in partnership with the National Association of Medicaid Directors, or us, and Wellbeing Trust. You all may know this, but the National Association of Medicaid Directors is a standalone bipartisan association that serves as the home for the 56 state and territorial Medicaid directors. We help Medicaid directors and their teams share learning, become effective leaders, and engage in the federal policy process as the consensus voice of Medicaid. We're pleased to partner with Wellbeing Trust on this component of the Medicaid Forward Initiative, and Ben is going to say a little bit more in a minute. But Wellbeing Trust is a national foundation that's dedicated to advancing the mental, social, and spiritual health of the nation, and we're really grateful for their partnership in this initiative. On today's webinar, you're going to hear from 3 folks. So myself, Lindsay Browning. You'll also hear from Ben Miller, who is the Chief Strategy Officer at Wellbeing Trust, and from Gretchen Hammer, who is the Senior Strategic Advisor at NAMD, and also the former Colorado Medicaid Director. And I had the pleasure of co-authoring this report with Gretchen and with Catherine Minnis from our team at NAMD. So first, to start us off, I'm going to turn it to Ben to help level set and share a little bit of the why for why NAMD engaged in this space and created this report. And again, encourage you all to ask questions throughout. So without further ado, Ben, let me turn it over to you.
Thanks, Lindsay. And I got to give my thanks to Gretchen, Diane, Matt, Hillary, Catherine, Jack, Don, the whole NAMD family. You all have been amazing partners in this work. As Lindsay mentioned, when Wellbeing Trust began its journey as a foundation for advancing the mental, social, and spiritual health of the nation, we knew that we would be limited in our impact without a meaningful Medicaid strategy. We knew the data on Medicaid, why it mattered for mental health and addiction. I mean, we would just list the ways it improves access, it saves lives, keeps people from going into debt, all the amazing things that Medicaid does for us as a society. And as a self-admitted policy wonk, while I do love Medicaid and probably will talk about it over pizza tonight with my kids, there's really nothing else like it out there. And how our states use their ingenuity and creativity can help countless. So we knew that we needed leadership in that space, and we needed it now, because what COVID has done has put our most sensitive cracks under a massive microscope. We knew that the mental health system was strained. People had to wait too long. Services, often life-saving services, were not always covered in a timely manner. We had a lot of work to do before COVID. And what the pandemic has done is given us a moment of reflection to really examine what wasn't working and what we might be able to do to build a system that people actually deserve and want. And that's where today comes in, and why this work we're going to talk to you about matters so much. But as a reminder, next slide, please, Lindsay. Our data have been going in the wrong direction for decades. We've lost too many lives to preventable causes, lives lost to drug, alcohol, and suicide, or the deaths of despair. And these are in large part why we continue to see the decline in life expectancy in the US. It's driven by these unaddressed issues that were some part social, some part economic, and many parts mental health. Deaths to drug, alcohol, and suicide continue to skyrocket that are reaching levels now that we've never seen before. And these issues impact all of us, all generations, all ethnic and minority groups, though at differing degrees of severity. In the best of times, our country still had not resolved itself that mental health and addiction were a big enough priority. Now, in the face of this global crisis, we're at a pretty critical pivot point for mental health, and we believe that this is a moment to rise to the challenge. Next slide, please. And as I probably don't need to even show you this slide, most of us have felt this. The country has seen an increased rates of stress, anxiety, depression, drug overdose. These data that you can see here are from our collaboration with Kaiser Family Foundation, which has some excellent information on mental health during COVID. We've all felt this, and we all know what this is like, and it yet still has not had enough action put behind it to bring us to a place that we can get out of it. And we're not out of it yet, but we still have a moment to actually do something pretty meaningful. Next slide, please. So when we add in social isolation, loneliness, on top of all the other things that I said, which we know we're already linked to a variety of mental and physical health problems, we have a moment to actually go deeper on why people are dying prematurely and what we can do for change. So we did an analysis which showed how deaths of despair could really only increase if we did nothing on mental health during the pandemic. This website you can see here at the bottom, the URL, actually shows you the data. And it's a really fun interactive website. It allows you to tinker with different factors and play into the various predictions that we had in the report, in a different report. My point here is that this is an urgent moment for us to think radically and to pursue solutions that can change mental health in all our communities. It's our time and action is needed. That brings us to today and the important report that Gretchen and Lindsay are going to talk to you about. So before we get going, Lindsay mentioned this at the top, we want this to be relatively engaging, which I know is hard to do in this virtual world, but we're going to try. So we're going to do a quick poll and see what you all think. So here's your question. What's your biggest concern about the mental health and well-being of the nation? We'll give you just a second to do that. All right, see the results. We need a drum roll here. Okay, 36%. Okay, so we had a close tie for first and second here. Constrained care and delivery system and workforce shortages. Absolutely. Depression, anxiety. Absolutely. As I already mentioned, we knew those rates were skyrocketing. We're going to talk a lot about this constrained care delivery and workforce piece. And it's almost like the perfect segue, Gretchen, to hand it over to you, because this is an area that as we were going through the report, we deliberated a ton on. Like, how do you go through robust change if you don't have the right workforce? How do you take these amazing integrated models and actually do it when we're already under so much pressure to just keep the lights on as it is? So I will turn it over to you guys, but thanks again for this wonderful partnership. We look forward to the discussion today.
Fantastic. Thank you so much, Ben. So I want to transition and tell us a little bit about why Medicaid Forward, what was the point of this process, why we created it. And Ben really laid the foundation nicely. The events of this last year have impacted us all in very real ways. From the loss of loved ones to social isolation, becoming caregiver, teacher, and a worker at the same time. So it's clear kind of that this has impacted the nation. And Medicaid has a really significant role to play in the recovery from the pandemic. Roughly 1 in 5 Americans rely on Medicaid or CHIP for health insurance. And we also know that in addition to being a major source of coverage, Medicaid is a key financer of the delivery system, investing about $600 billion each year in the healthcare infrastructure. So Medicaid has a critical role to play, particularly in areas of our healthcare delivery system where Medicaid is the predominant payer. Mental health and substance abuse being the key one and the first area of focus in this work. Access to care for children. We know that children's health has been really impacted through the events of this last year. And then, of course, supports for individuals in need of long-term care. So what Medicaid Forward is a strategic framework of options shaped by Medicaid leaders, shaped by national experts through an executive working group structure that will help Medicaid programs contribute to the nation's recovery from the pandemic. Medicaid Forward Behavioral Health, as I mentioned at the outset, is the first of 3 reports that provide the strategic framework of options. I don't need to elaborate too much more because Ben really laid the landscape, but we know that anxiety and depression are on the rise. And we know that even before the pandemic, Medicaid covered 11 million individuals over 18, so 11 million adults with mental health conditions. So those numbers are on the rise, and Medicaid's going to have an increasingly prominent role in delivering the behavioral health care. So Medicaid for Behavioral Health provides this framework, this menu of evidence-backed, sustainable policy and program options that state Medicaid programs can look at and identify, what makes sense in their context, in their state, to help address this need. And it's specifically laid out as a framework of options because we know that what works in one state may not work in another state or be responsive to the context of that state. So this really is intended to be a menu of options rather than a set of recommendations or a roadmap. The report looks at opportunities that Medicaid can use to kind of address the broad population, right, to meet the behavioral health needs of all 77 million members. But we also recognize that there are opportunities and perhaps more specialized levers that are needed to be applied to unique populations in Medicaid. So the report also looks at what are some of the strategies we can use to meet the behavioral health needs of children, of older adults, of individuals experiencing homelessness, of individuals with intellectual and developmental disabilities, and then, of course, folks who are transitioning from the criminal justice system and into the community. And we're going to get into some of these strategies in just a minute here. But I would like to point out, too, that the report includes an appendix that I'm particularly excited about because I think this is the kind of information that can help our state Medicaid colleagues take an idea and begin to explore it deeper and see if it might work in their state. So the appendix includes kind of real life state examples of places that have used these strategies, as well as some additional resources. So here's our list of executive working group members, and we really do want to express our thanks and appreciation to them for making this possible. They dedicated a lot of hours and time to meeting with us virtually, reviewing the report, and helping us really shape a product that can be helpful for all 56 Medicaid programs. So our deepest thanks to them. So without further ado, I'm going to turn it to Gretchen to take us into the first section of the report, which looks at some of the opportunities and strategies Medicaid programs might use to meet the behavioral health needs of all members. Gretchen?
Terrific. Thank you so much. And thank you for everyone to join us. We're just thrilled to have over 80 people joining us. And I was looking through the attendees, and we have some members from the executive working group, so welcome, as well as I've seen a couple of colleagues from the state of Colorado, so welcome to you all as well. The discussion that we want to start off with is, as Lindsay said, that broader set of strategies that we identified through the executive working group, where Medicaid can play a role, as Lindsay so importantly said, in contributing to the nation's recovery from this pandemic. I want to acknowledge that the place that the poll identified as a potential area of concern or worry is the workforce and the capacity of the system. We recognize that and wrestled with that as well, but couldn't let that diminish our focus on what could be possible, right? If we just stopped with that, we may not have enough capacity in the system, we wouldn't have been able to articulate some options, but we acknowledge it, but try to also say, putting that aside for a moment, what is it that we need to think about and what is there evidence to support as ways in which Medicaid could contribute to the nation's recovery and, as Ben so eloquently outlined, really address the behavioral health needs. So what I would describe these as, these initial strategies that we outlined, is really foundational mindsets that need to undergird our response in the short term, but really also set us up for long-term recovery and what we all hope for, which is that our nation will thrive, both in our health and in our well-being. So the need is universal right now. As Ben's indication and probably all of our own lived experiences, this last year, no matter how you have experienced it, has been unique and has been very difficult in many different ways. So one of the key concepts was to begin to think of the universality of the needs of the Medicaid population, just like every other population, and how we need to think both proactively and holistically as we think about using the lever of Medicaid and bringing the promise of the Medicaid program to bear to address the needs of the behavioral health needs of our nation. So one area of focus really has been advancing prevention and promotion, that we have to be focused on not only acute care and sort of tertiary levels of care, but that there is a real responsibility of the Medicaid program and opportunity, especially as it relates to children and their families, to be on the front side, if you will, to advance promotion of mental well-being and really advance prevention of conditions that can be more challenging to manage later in the disease process or later in life. The second area was really streamlining access to services, right? Historically and probably currently, there are diagnostic criteria, there are utilizations of criteria that need to be met. And the executive working group thought there's an opportunity to perhaps streamline some of those current requirements in Medicaid programs to accelerate access. Of course, we have to balance that with being good stewards of the resources that we are entrusted with managing, but that there's also such need and such an opportunity to be responsive that streamlining access to services was another area of key priority. The other would be, I think, touching on the area that was identified in the poll, which is we know and recognize that all community-based models of care right now have been impacted. The move to telehealth, the stress and strain of care providers, making their capacity to provide services less, that we really needed to double down, if you will, on the concept of integration and on the commitment of all components of our healthcare delivery system to address the both physical as well as behavioral health needs, including substance use disorder. So a real opportunity to continue to think about advancing integration, which many Medicaid programs have already taken action on, but continuing to promote it. Another area that we talked about as a way in which Medicaid programs can think about making changes or advancing new ideas around meeting behavioral health needs is to think more broadly about addiction. We have in the past had investments based on a single addictive substance, opioids being an example, but we recognized, and the executive working group saw as an opportunity to sort of broaden the frame on addiction treatment services to include all addiction, but also to recognize, as the data is showing, that people who struggle with substance use disorder or addiction have had probably their supports limited during the pandemic, and we need to make sure that their supports are back in place as quickly as possible. And then finally, sort of building on that, the need to strengthen crisis. Many of you who have worked in the Medicaid program for a long time, or who have worked on behalf of or in partnership with Medicaid, know that the crisis services are often managed in a different part of government, and that there's always been an opportunity to perhaps strengthen the relationship between crisis response and Medicaid. And some states have really taken action in that area, the state of Arizona as an example. And as the national framework of crisis is evolving, our executive working group saw opportunities to strengthen crisis within the Medicaid program as well. As Lindsay said, these are outlined in our report as options for states to evaluate to see what meets their needs and where they might be able to take action given the experience of the beneficiaries in their state resources, et cetera. But across these concepts, the executive working group really endorsed these as ways in which evidence-backed ideas could be pursued by state Medicaid programs to improve the behavioral health needs or to meet the needs of all of the members of the population. Lindsay, I think we're going to the poll next, correct? Terrific. So there's the more detailed level, and you can see in the report the sort of action items, if you will, that go under each of those areas for those strategies. But I think, Lindsay, the poll question is, where do you all see the biggest opportunity for Medicaid programs across the nation to take action, again, as we contribute to the larger healing of our nation? And we've given you these, but we've also given you another option because certainly we recognize that our framework is not comprehensive and that there may be other opportunities that you all have identified. Terrific. So Ben, I know that this is a particular area of your expertise and focus, but it looks like our poll winner has been continuing to promote integration of physical and behavioral health, and then followed by streamlining services. So Ben, do you have some reflections on that?
Well, no, I mean, it's obviously the right answer, hence so many people picking. No, I think this is right. I mean, we joke about this a lot because we've been fighting fragmentation for decades, and many of you that are in the Medicaid space have had to enter into situations where you've inherited almost fragmented programs and administrative policies, et cetera. So that drive to promote integration is definitely on the horizon, and I'm so glad to see that it's a priority for each of you.
I agree. I think that it's a real opportunity for every encounter with the healthcare delivery system to include a focus on comprehensive well-being that is broadly defined. And we know that there's structural ways we need to do that, and there's cultural ways we need to do that. And I think continuing to build on that seems like a really important opportunity. Lindsay, I think you're taking the next section on the populations that the executive working group identified as having either unique behavioral health needs or a unique lever that the Medicaid program would have the ability to pull, for lack of a better word, to meet the needs of that population.
Yeah, thank you, Gretchen. And I think you can see from this graphic here that we envision that, there are supports and strategies that Gretchen talked about that can meet the needs of all members. But when you're talking about some of these special populations, you may need to layer on top of those some additional strategies, some specialized supports. And so we asked the executive working group to help us identify, what are the key special populations that we should highlight, that we should dig into. And these are the 5 that they identified as a group. And we recognize this isn't the universe of special populations in Medicaid, but it's the ones that rose to the surface where Medicaid does have a unique opportunity at this moment in time to meet their behavioral health needs. So I'm going to dig into these 5 in a little bit more detail, but would encourage you all to take a look at the report and the appendix, which has some good state examples around each of these groups. So first, I want to talk about individuals involved in the criminal justice system. This is a particular opportunity for Medicaid expansion states that are serving most individuals when they exit the criminal justice system. And we know that the data tells us that when individuals come out of the criminal justice system and they have a substance use disorder, they are at significant risk of overdose and death. So Medicaid has a really important opportunity here to address that issue. So kind of going back to that frame of starting first with prevention, there's really an opportunity that we highlight in the report to think about using crisis services as an opportunity to prevent incarceration. We know from the data that individuals are more likely to interact with the criminal justice system, more likely to interact with police than receive treatment when they're in mental health crisis. And that jails and prisons have become the de facto mental health treatment system. So we highlight opportunities in there to think about how crisis services can reverse that trend. The other opportunity we look at in the report is how might we kind of smooth that transition of care between the justice system and the community, and what are the opportunities around eligibility strategies and around care coordination and in-reach into prisons and jails to help smooth that transition and improve some of the health outcomes. So those are some of the strategies around individuals involved in criminal justice. We also took a deep dive into the needs of children and where Medicaid might have opportunities to respond, particularly to the trauma and the stress that children have experienced over this past year. And the first area of focus around children is, what are the opportunities to remove barriers so that children can receive behavioral health services in a timely way, particularly recognizing that kids who've experienced the events of this last year may just need some light touch behavioral health services and may not have a diagnosis, or it may not be appropriate to apply a diagnosis. So thinking about how to increase access to services there. The other piece we talked a lot about as an executive working group is how to address the needs of a child and a caregiver as a dyad. Recognizing that it's hard to do one without the other and see a positive impact. So those are kind of some of the unique opportunities there, as well as some longer term opportunities we look at around how do you partner with your sister state agencies, with other sectors to meet children's social and emotional health needs. And that's sort of a longer term set of strategies and opportunities, but nonetheless, really a key opportunity. We also look in the report at the needs of older adults and what Medicaid might do to address the increased behavioral health needs there. And we know that Medicaid covers 12.2 million individuals who are also eligible for Medicare, and that there's a particular set of complex needs among that population. So some of the opportunities we look at there is, what can Medicaid do to respond to the fact that older adults are really feeling the brunt of the social isolation, and that's impacting social and emotional well-being. So things like peer supports, things like case management, to help mitigate that. We also, again, here talk about maybe a longer term strategy, which is how do you think differently and transform the way we deliver behavioral health for older adults, particularly thinking about value-based purchasing strategies or incentives, quality incentives that seek to address that. Similarly, we dig deep into the needs of individuals with intellectual and developmental disabilities. And I'll be honest, I think this is one of the opportunities where we as a Medicaid policy community can continue to dig deeper and think about the strategies to add to the toolbox here. But the ones that we address are really aimed at thinking about how we make sure individuals with co-occurring intellectual and developmental disabilities and mental health needs don't get shuffled around the delivery system between IDD providers and behavioral health providers, but really how we build the capacity to treat them in a person-centered, holistic way. So we suggest in there some strategies around starting with the data, around shoring up the key supports that we know are important for the health and well-being of these individuals. And then thinking about building capacity for specialized services, particularly specialized crisis services that are responsive to the needs of individuals with co-occurring disorders. Finally, we look in the report at the needs of individuals who are experiencing homelessness or housing instability, and both in the traditional sense of homelessness being a key challenge among individuals with serious and persistent mental illness. But we also know the events of the last year have really impacted the stability of families, and that more families are and likely will experience homelessness. And that can impact the mental health and lifelong trajectory of families and children. So the opportunities we look at here start with thinking about, are there barriers to getting folks enrolled in coverage who are eligible, such as issues around income reporting or address reporting? Are there data strategies that programs can use to identify who is at risk of homelessness or experiencing homelessness, like data matching, like having MCOs conduct screening? And then moving down the continuum, what can Medicaid do directly to provide supportive housing? Can't pay for rent, we know that, but are there opportunities to provide the wraparounds that can help individuals stay in housing or gain housing? And then, of course, thinking about where are tailored behavioral health services needed that are responsive to the unique circumstances of these individuals, things like targeted case management. So clearly a whole range of opportunities from kind of the data to the services themselves. So I want to turn now, I know that was kind of a quick dive into our areas of focus, but I want to turn to Gretchen to hit on the last section of the report, which I think is a really critical piece that wraps around all of the, nuts and bolts of the levers we've talked about here. So Gretchen, let me turn it to you.
Sure, Lindsay, and I want to thank the 2 participants who've used the question and answer function. So that is an option. We also, I think, will continue to try and use that, but I wanted to just respond to those 2, Lindsay, before we jump in. The first question, if you didn't have a chance to see it, I tried to respond to it in writing, was, what was the criteria that was used to pick what fit into this report, right? This is a massive area of effort and of complex Medicaid policy. So we really tried to use the consensus of the executive working group. As Lindsay mentioned, we had some outside experts as well as leaders from 8 states who manage the behavioral health supports of their program every day. So we wanted it to be actionable. We wanted it to be something that could be moved on in the next year. We recognize, as Ben said, there's going to be a long-term recovery, but that some of the typical approaches of the Medicaid program with waivers, 1915, B, C, I, the alphabet soup of the Medicaid federal authorities, 1115 waivers, those can take years to negotiate and to implement. And we wanted to find strategies that felt like, with typical Medicaid administrative flexibilities and administrative focus, these are strategies that a Medicaid program could contemplate to be responsive to their needs. So that was a little bit of the criteria, but mostly it was consensus by our executive working group members. The second question was around integration, and this again may be a place, Ben, where you can provide some insights, but the question was, how do we not make integration in physical and behavioral health compromise access to more specialized behavioral health services when someone may need it? And what we talked about is a high quality integration model is a continuum, that there's an opportunity for low acuity or common or typical behavioral health conditions. For example, I think one example we talked about was a woman who's just given birth, right? That's a change of life, right? And there's well-documented evidence that for some, can be depression. That though can, for some women, become significant and severe, in which case there has to be a transition, first a recognition, and then an appropriate transition to the higher level of care that's needed. So we really talked about it as a continuum, and where we know that all of these models don't always work perfectly is that transition point, right? From the primary care management, and that happens with every condition that all of us have experienced. So Ben, I'll let you talk to that question.
Well, I mean, Gretchen, you said it beautifully, and I love the question. I mean, you've got to meet people where they're at. And unfortunately, in some of our communities, we limit where people can get access to mental health. And so this is no attempt to undermine or in some ways, change the specialty mental health aspects of what we need. As Gretchen said so beautifully, it's on a continuum. It's really to maximize the efficiency of the different care pathways that can emerge when you provide new avenues for people to engage mental health services wherever they might show up. And in the report, you'll see this. I mean, we talk about and lift up some of these high touch areas like primary care or schools, because it is a place that a lot of people go that have need. Now, the challenge, and I think you'll see this as you get into the meat of the report, is how do you coordinate all that? So as we drive to integrate more efficiently and more effectively, how do we coordinate those various pieces throughout our Medicaid programs? And I think that is going to be one of the big battles that we have to face when we have conversations later today. Thank you.
Great. All right, so Lindsay, I'll get back on track here, and I think I'll answer the next question in my components here. So the essentials for success part of our report really came through from the ongoing dialogue of the executive working group that essentially said, no matter what you pick to work on, there are certain things that have to be in place to make that effort successful, right? There's a sea of opportunity, a sea of options that a state could contemplate working with their stakeholders, but all of them would sort of hinge on these 8 core elements. And so the first is leadership, vision, and collaboration. In many states, the mental health agency is not within the Medicaid agency. In some states, they're aligned or they're under a larger health secretariat, but the interplay and interaction between the Medicaid agency, the public health department, the mental health authority in the state, that really requires collaboration, leadership, and a shared vision across that infrastructure. Similarly, even within a Medicaid program, that collaboration and vision is really important. The other is that this work requires a long-term commitment, right? We're trying to say there are things we could move on quickly, but the world changes, administrations change, and real long-term transformation would require leadership to hold the ship steady through all of those transitions. The second thing we talked about is the criticalness of member engagement. So the question we asked was, did we include consumer groups in our process? And the answer is yes, in some ways, but probably in a place where we have more opportunity to continue to explore and do better. So what we did for each of the sessions that we had of the working group, we used the resources of our known consumer advocacy groups across the country and tied in the agenda items to either patient stories or videos that those organizations had produced that illuminated the need. NAMD also has a library, for lack of a better word, of member engagement materials that they've had from the opportunity to engage with Medicaid members from the state. And so we highlighted those that were relevant. So for example, one of the stories that we know of is an individual who spent time in prison, and he recorded a video for us talking about his experience upon release and his experience leading his life after his period of incarceration. So we tried with those tools. We think there are opportunities to improve in that area. So for example, at our children's one, as Lindsay said, we're trying to use our partners at Family Voices to join one of our calls and talk about their lived experience of working with the families they support during the pandemic. We want to mirror that in the report by saying that Medicaid programs really have an opportunity to engage their members, to ensure that any of the options they may pursue that are in this framework are grounded in the member experience and guided by member need, as well as how we're sure that whatever policy is made would actually meet the needs and be constructed in a way to meet member needs. Similarly, we talked extensively about a commitment to equity. One area in particular that we talked about this is, the quick innovation to telehealth was obviously critical to the response of the pandemic. But I think many of our executive working group members are asking the question and wanting to ensure that we're taking the time to pause and ensure that those kinds of rapid interventions, like the shift to telehealth, are being experienced in an equitable way. We also know that because of our larger structures of inequity in our nation, the populations that we identified that have experience in the criminal justice system, as well as experiencing homelessness, because of those structures, there's a real important focus on an equity lens as a Medicaid program approaches any opportunities in that area. The second, I think, of this notion of sound administration ties into that conversation about the telehealth. And really, when we move quickly, which I know some people don't know that Medicaid can move quickly, but I think we proved that we can. It's great to move quickly. It was critical to the response, but we also have to stop and make sure what we moved quickly on is doing what we thought it was going to do. And that's whether it's a quick move or, for example, Ben, when we've prioritized integrated care, is it really delivering on what we think it was designed to deliver on? And to answer that question, you often need both member engagement and member experience and data. And so another essential for success was, where are we, one, seeking data to understand the needs of those that we aim to serve, and two, using data smartly as we implement interventions or changes. We tried really hard to hold payment to the end of our discussion. We know that many of the concepts that we've talked about have a payment component. And really the idea here is, as Lindsay said, in particular for the strategies we focused on for older adults, that the flexibility, for example, of the payment structure for the PACE program perhaps gave them an ability to be responsive to the urgent and emergent needs of older adults. And that how do we continue to look at which of our payment processes and payment models are best fit for the interventions and the innovations that we're trying. As we talked about, workforce is a major challenge. It's an area of concern, was an area of concern prior to the pandemic. It is absolutely an area of concern now. And so we have to contemplate and balance any good idea that we're pursuing with the reality of whether or not the workforce will be available to actually successfully implement a change or launch a new program or whatever our ideas may be. And then lastly, change management and technical assistance. This is always critical in any transformational effort, but the working group really prioritized that when you're working with folks who have been exhausted by a year of pandemic response, whether that's state agency, community-based partners, providers, really being thoughtful about what is this pace at which change can be absorbed and what's the technical assistance needed for supporting that change to be successful. So again, these essentials for success were really crafted as an undergirding, if you will, of any of the potential priorities that a state could choose out of this framework. Lindsay, I think we have a poll now. Terrific. So similarly to our last one, we'd like to learn from you all what you think is most important for our essentials for success. And then also we've given you an opportunity to put other if you think we've missed something that's foundational. So I invite you to complete the poll. Terrific. So as a person who's really invested in the success of public leaders, I am thrilled to see that leadership and vision and collaboration are the top vote getter here, if you will. But I don't know, Ben, if you have, given your role as a national leader in this space, some reflections.
Yeah, I'm really glad to see this too. You know, one of the things that I think we've stumbled upon in working with states is that sometimes there's inconsistency in vision when we use words like integration. And I think the drive as a leader to create a strategy that allows you to bring multiple stakeholders together, because literally integration is about pulling the pieces. And the pieces oftentimes represent different sectors, different cultures. You got to have a vision of what good looks like. And if you don't, then unfortunately what happens is a lot of that noise, that cacophony. So I think that it's critical to have the ability to know where you're going, but, and this is key, and I think Gretchen, you've modeled this before in your career, but how do you make sure that you bring the right people to the table and then lead appropriately so that folks can then make progress on that goal? That is the art. And that's something that I know that NAMD has talked a lot about in terms of leadership, but it's really critical that as we're on the front lines of doing this redesign, that we listen closely to people's concerns, because a lot of the things that are in here, while they might be common sense to some, they might be radical to others. And we've got to make sure that we meet people where they're at so that we can kind of work towards that collective goal together. So happy to see this one.
Terrific, terrific. So Lindsay, we have two more questions. I think I can take the first one about examples of integrated care, and Ben, maybe you can offer some additional, but then there's also a question about federal policy. So Lindsay, I'll let you think about that one and then take that one on. So the question was, are there good models of integrated care, of how we can better integrate and align physical and behavioral health? And again, Ben's a national expert on this, and there are examples in the appendix of the report of some states. I will put my former Colorado Medicaid director hat on for just 2 seconds to talk about some of the work that we did. So our state innovation model was focused on integrated care. So a federal grant from the Center for Medicaid and Medicare and Medicaid Innovation. But in addition to that, in our work to better align behavioral health services and physical health services, we tried to articulate a policy that would allow for what we called short-term behavioral health services to be provided in a primary care setting. So we made a payment policy change to to allow for a certain set of behavioral health codes that had to be delivered by a licensed behavioral health provider in a primary care setting, that they could bill the state Medicaid program for those services and not require a diagnosis, not have to navigate the capitated behavioral health system. Again, the idea was for someone who was experiencing grief, or for a child who was very young, for whom there wasn't a comfort level among the clinicians to diagnose, a 2 or a 3-year-old, but really thought that that child or that family experiencing grief could benefit from some licensed behavioral health support. So those 6 visits, as they became colloquially known, of short-term behavioral health services were allowed to be billed from a primary care space. What we hoped that did was allow a pediatrician's office or another office, primary care provider, to hire with confidence a behavioral health provider, knowing that they would be able to provide services to Medicaid enrolled members and to bill the Medicaid program for that. We did limit it because the thought was there is an entire behavioral health benefit that has an infrastructure that was important and included, as I think our earlier question and discussion of integration talked about, more comprehensive behavioral health supports. But was a policy choice that we made to try and allow for that. The state of California has also recently done that for young children, a very similar policy, again, trying to make behavioral health supports available in the primary care space by licensed behavioral health providers. Ben, I don't know if you have other examples or something to add.
Yeah, just one quick comment, which I think you said, but in the report, one of the beautiful things that the NAMD team did is that when you look at the state examples, there are hyperlinks that actually take you to the source document. So you can see our summation. Oh, am I getting ahead, Lindsay? You've already got that. When you look at the example that's in the appendix, you can click on that and it will take you to the source, which actually allows you to go a little bit deeper into some of those decisions. And to my colleague in Florida who's working on this, all states have been at a place where they have struggled to really get started or have struggled to have a blueprint or a roadmap. And if you're in a perfect scenario, what you do is you kind of take the pieces from around the country and you create your own hybrid of that, because I think that we're learning that there needs to be enough flexibility built in to how practices on the ground ultimately implement your vision of integration, but there needs to be some standard set in terms of quality and outcome so that you actually can make sure that people are doing what they're supposed to be doing within that flexible approach. So that's one thing. The second thing, and this is just almost a throwaway comment, but I have to say this, it goes back to the previous poll that we did on leadership and vision, that you've got to set your own vision and then talk to folks that might have gone near that city on the hill that you're working towards. They might go near the North Star that you're following, and then learn from them as to how they were able to work into their process, stakeholder engagement, measurement development, financing, multi-stakeholder engagement, all that's, multi-payer engagement, all that stuff really does matter to ultimately accomplishing your goal. So I'll pause there.
Great, and I can take the question around federal policy. So this report really focuses on the opportunities that state Medicaid leaders have, but I think a natural outflow from that is what are the federal policy opportunities and barriers that can facilitate or hinder some of these strategies. And I think we already know kind of what some of them are, and they've been long-standing federal policy issues for NAMD, like the institutions for mental disease exclusion. But I think there are others that are probably going to become clear as folks start to implement or pursue some of these. So NAMD's federal policy colleague, Jack Rollins, was very involved in the conversations and listening to the executive working group. And I think it intends to pull some of this into NAMD's conversations about how do we engage with the new administration and what are the consensus areas of focus for the Medicaid directors. Great.
Lindsay, are you state examples?
Yeah. So we have the appendix here, and I pulled up the slide because Ben already alluded to this. But the appendix, as I mentioned at the outset, is I think a great resource for folks to take a look at. We tried to provide examples for a lot of the strategic options discussed in the report. And as Ben said, linking to the source material. So if you're a state Medicaid agency leader and you're interested in what Illinois did around screening, you can go take a look and see what they're doing. Or if you're interested in Massachusetts work around individuals experiencing homelessness, you can link to that source material and dig a little bit deeper. We also have a lot of national resources that look at some of the evidence base for the strategies described in the report. So again, an opportunity to dig deeper and think about some of the options in here. So that is our last slide. I would love to take any additional questions if folks have those, but let me just give a moment to shout out and say that we're available as a resource on this topic, on the information in the report. So you can feel free to contact myself if you have questions, and we'd be happy to discuss it in more detail. So let me stop the screen sharing and would love to take any additional questions from the group. Okay, we may have answered them all.
Great work, guys. This is such an important report. I look forward to hearing people's thoughts. So if this is your first exposure to this product, definitely let us know. I mean, you can pepper Lindsay with all your emails, but I think feedback is needed. As Gretchen said at the top, I mean, there's a lot of options in here for us to pursue. So if there's things that you think, hey, I'd really like to learn more about that, or things you feel like we totally missed on, just let us know. I mean, this is part of the brilliance of the Medicaid Forward model, is that we are trying to push for something that is going to be bigger and better for the next generation. So look forward to hearing your thoughts there.
Great. And I just want to echo that thanks and appreciate you all attending today, for your interest in learning about this report and the Medicaid Forward process. And please keep your eye out for our additional 2 reports that will be coming out over the coming months around children's health and around long-term care. Gretchen, any final words?
No, just thank you all. It's always exciting to put together a report and have such an amazing executive working group process to help craft it and then get to share it. So we really appreciate your attendance and hope that you'll stay engaged in NAMD programming and engaging with your Medicaid directors at the local level if you're from a state.
Thank you all so much. Have a great rest of your day. Bye.